I've been looking forward to it. So I'm going to talk about circulating tumor DNA use in GU cancers. And okay. Alrighty. And I'm mainly going to focus on bladder cancer. I think we've seen most progress in this area, and that's also my major expertise in that field. So I'll show you some of the results from that. These are my conflicts of interest. I'm going to show some data generated together with the C2I Genomics, Natera, and AstraZeneca also. So I think we all know that circulating tumor DNA and cell-free DNA is constantly being released. Cell-free DNA from healthy cells, and if there's a cancer in the body, then these cancer cells are shedding mutated DNA or other alterations in the DNA that we can measure in the plasma. And that's the main focus on this, that we can actually use these molecular alterations in the plasma as a molecular tool to track the disease course. ctDNA is highly fragmented. As we can see here, only about 150 base pairs protected by the nucleosomes, and we can measure it in the urine also from renal clearance. It's important to say that when we're working with circulating tumor DNA, one of the advantages of this is that cell-free DNA and ctDNA has a half-life of about 2 hours or below. That means that we can actually do some real-time measurements of the tumor burden during treatment and after radical cystectomy, for instance. So circulating tumor DNA really have the potential to be used throughout the disease course, as we can see here, from early screening stages here, prognostication just before surgery, for detection of residual disease after surgery and after radical cystectomy, and then for monitoring treatment response during treatment and monitoring resistance also. It's important to realize when we are talking about these different techniques of measuring circulating tumor DNA that these techniques here are based on different assays where we don't have information about the biology of the individual patients yet. So this is tumor-agnostic approaches. And then we have tumor-informed approaches when we have a tumor where we can design some really specific and sensitive assays for monitoring the patients. And I think it's needless to say that these tumor-agnostic approaches are more difficult to handle because we don't know exactly what we're looking for and what we're measuring. So that gives us some challenges here. So cell-free DNA is not a new field, as you can see here. It was actually discovered in 1948, reported the first time. But it's really in the recent years where we've seen some really progress in this, and it's really been driven also by the technological advances in digital droplet PCR and next generation sequencing also, and especially in the prospective studies and the clinical trials that are running now, where we start to see some clinical benefits of using circulating tumor DNA. So first I would like to talk about MRD and metastatic relapse detection using circulating tumor DNA. What do we know? So we published this study a couple of years ago, or some years ago now. I think it was one of the first prospective studies of circulating tumor DNA in the neoadjuvant setting here. So we selected all these different blood samples here throughout the disease course from the patients, collaborated with Natera and used the Signatera test. It was a Amdicon-based test of 16 mutations. And this is one example. What we see when we measure circulating tumor DNA is that we see here during neoadjuvant chemotherapy, we see positive tests here that are actually going down and becomes zero after neoadjuvant chemotherapy, indicating that the treatment is actually effective in this case. And after cystectomy, we see a zero, and then it rises here to a positive test. And this positive test is actually 245 days prior to detection on the CT scan. So it opens a window for earlier treatment of these patients. So if we look at the full cohort in this study, we could see that the circulating tumor DNA detection before chemotherapy was highly prognostic. After chemotherapy, before cystectomy, it was also prognostic, but really in the setting of MRD and metastatic detection after radical cystectomy, we see this really high prognostic value of circulating tumor DNA. We see that circulating tumor DNA in this study has a lead time around 3 months over CT scans, also again opening a window to earlier treatment of the patients. We have been performing now a follow-up study on this in this cohort where we have a full clinical follow-up on the entire cohort. And again, when we do this, we can see here again that when we have a long-time follow-up of the patients before neoadjuvant chemotherapy, the circulating tumor DNA status is highly prognostic, also before radical cystectomy. And if we look after cystectomy, we also see that it's highly prognostic. But when we have these long disease courses, we can also see that we start to see some clinical events occurring very late in the ctDNA negative arm. And of course that makes sense because the tumor keeps evolving and we cannot predict what goes on maybe 5 years out in the future. So it indicates that this may be a test in the early window after radical cystectomy. In this study, we also looked at a cohort of patients that didn't receive any neoadjuvant chemotherapy. And when looking at that, measuring just before radical cystectomy and after radical cystectomy, we can see that ctDNA is also highly prognostic of outcome in this setting. So we investigated this a little bit further and looked at patients that are circulating tumor DNA negative and compared between cohorts. Of course, we need good clinical studies to do this. This is something we should be a little bit cautious about when comparing between different cohorts. But when we do this, we can see that the recurrence event in the NAC-naive cohort is 5% here compared to 0% in the NAC-treated cohort in one-year recurrence rates. But it's not really significant. So there's no significant difference in recurrence-free survival here. If we look at the ctDNA positive patients compared between the cohorts, we also don't see a difference. So this actually questions the efficacy of the neoadjuvant chemotherapy for this. Is it really needed? So what we can say here is that we really need a randomized clinical trial to document if neoadjuvant chemotherapy is actually needed in ctDNA negative patients before or at diagnosis. So can we actually, so what I've been showing you now is data based on the Signatera tests and where we're using a 16-plex amplicon PCR. But what about if we use whole genome sequencing? Does it actually become more sensitive or better or easier to use? This shows a sort of a schematic representation of what happens with the p-values if we go from a single mutation and a probability of detecting circulating tumor DNA in a sample, and when we go to tens of thousands of mutations from whole genome sequencing. So we can actually see when we do that, theoretically, we have a much higher probability of detecting circulating tumor DNA in less, where we sequence less and where we have a lower volume also of this. So in theory, it should be better to go for whole genome sequencing of this. So what we did in this study in collaboration with C2I Genomics was that we did whole genome sequencing of tumor and germline and built a model based on the mutations, indels, and copy number alterations in the tumor and applied that model to 20x sequenced whole genome sequencing of cell-free DNA from plasma samples and then identified if we saw ctDNA in the patients or not. And this is the result from this study here where we have 112 patients here. So you kind of see the below here. This is on bioRxiv. So it's prospective testing again. We see these patients here. They all have metastatic disease later on, and they have circulating tumor DNA detected very early, also actually at diagnosis or during the neoadjuvant chemotherapy. And patients here that don't show any signs of clinical relapse, most of these have green circles indicating they have ctDNA negative tests. Again, if we look at the survival plots for these patients, we can see again, similar to when we used the other tests, using this whole genome sequencing approach, we have an indication that this is a highly prognostic marker before chemotherapy, before cystectomy, and especially after cystectomy also where we have a high power of this biomarker. So importantly here for this test, if we look at lead time of this test over CT scans, we can see here for this we have approximately 4-month lead time. And what's interesting also, if we look at the accumulation of cfDNA in patients that relapse, we detect ctDNA very early on compared to here where they don't relapse. We detect very few events of ctDNA. So it's a very early event also, as we saw. So what about treatment response? And how can we use ctDNA as a treatment response measurement? So we looked at that during a neoadjuvant chemotherapy for some patients here. We did that in the earlier study I mentioned, where we compared it to pathological downstaging, where we saw the dynamics of ctDNA in some cases were highly correlated to pathological downstaging and no pathological downstaging. We also saw some discrepancies where we saw a drop here in ctDNA but no pathological downstaging. And if we compare that to clinical outcome and recurrence of the patients, we can see that pathological downstaging in this case is actually not significantly associated with recurrence, but ctDNA dynamics is in this case. This is still few patients and we need to include more for this, but it makes sense that the ctDNA dynamics in the system is a better measure of distant metastatic relapse. We did the same in this study using whole genome sequencing, 20x coverage. And again, here we saw that the dynamics, positive, negative, and clearance of ctDNA during neoadjuvant chemotherapy before NAC and before radical cystectomy was associated with pathological downstaging. And also, if we look at the outcome of the patients, we can see that the clearance and all negative and remains here is highly significantly associated with outcome also for the patients. Pathological downstaging is also here associated with outcome, as we expect also. So what about comparing the plasma levels to urine ctDNA also and use that as a combined biomarker for outcome of the patients? So we did this in this study here where we did a homebrew panel sequencing of 50 mutations per patient and then looked at plasma samples and urine samples taken at the same time and then looked at how this is correlated to clinical outcome. When we do that here, we have the plasma and the correlations to pathological downstaging, and here we have the correlations to outcome and recurrence-free survival of the patients for plasma, and this is the results from urine supernatants, again, where we see a similar tendency, but not as strong as for plasma data. But again, we can see if we have urine tumor DNA, then we have a poor survival compared to clearance. And if we combine that, now we're down to few patients here, but if we combine it, we can actually see we can identify a group of patients here with very good outcome and a group of patients with poor outcome. So what we would like to use this for, and we discussed it a little bit earlier also, can we actually use it for some bladder preservation approaches where we have, if both urine and plasma is negative, then it may be used for bladder preservation. If blood is positive, then it may be a radical cystectomy, or if both is possible, then positive, then we may change treatment regimens for the patients. So it's something we need to look more into. Of course, there is this study here also that's been really driving the field here in bladder cancer, the IMvigor010 trial that had a negative endpoint, but when stratified by circulating tumor DNA, it was actually possible to see that patients that were ctDNA positive had a survival benefit of receiving atezolizumab in this study. And that's reflected in the survival curves here also when they look at the dynamics of the ctDNA during treatment. So which trials do we then have and how can we use this to guide treatment of the patients? I think this is really important that we do these clinical trials instead of just jumping out into starting using the ctDNA before we actually know if there is some clinical benefit of this. So right now there are two ongoing clinical trials. There is the IMvigor011 trial where ctDNA positive patients are randomized to atezolizumab versus placebo. Primary endpoint here is disease-free survival in patients that are ctDNA positive. And then we are running in Denmark a trial called Tombola, and this is where it's a non-randomized trial where ctDNA positive patients receive atezolizumab. And the primary endpoint here is different from the other one where we look at a complete response defined as a clearance of ctDNA during treatment. And the Tombola trial is here we collect patients or enroll patients from 5 different clinical centers in Denmark. And Tombola is for treatment of metastatic cancer at the time of biochemical relapse following radical cystectomy. And this is the outline of this study. So basically we take blood samples at diagnosis during neoadjuvant chemotherapy before cystectomy and all these different time points after cystectomy. We use this window here to design the different assays that we're using. Here we use 4 to 6 different digital PCR assays developed at this time per patient based on a whole exome sequencing of the tumor and the plasma or germline from the patients, and then use those assays to track the disease burden after radical cystectomy. If they're positive, they enter an immunotherapy regimen here with atezolizumab. So this is ongoing. We have 175 patients enrolled now. Approximately 50% of these patients are ctDNA positive after cystectomy and have started atezolizumab treatment. We plan to present an interim analysis of this at ESMO in 2024 and start to analyze on this data. And then there is this new trial here, also planned initiation in 2024 from Matt Galsky. It's a little bit annoying that we cannot see this, but this is PI is Matt Galsky here. And in this trial, that's all patients that can go into this trial, and if they're ctDNA positive, they're actually escalated to additional treatment in this arm here, and if they're ctDNA negative, they have a sort of a de-escalation where they will enter a surveillance phase instead of receiving nivolumab. So that'll be interesting. So my conclusion from this is that circulating tumor DNA in muscle-invasive bladder cancer is a powerful biomarker. We can use it for risk assessment before treatment and cystectomy. We can use it for early diagnosis of MRD and after radical cystectomy, and for monitoring response during chemo and immunotherapy, as we have seen. We really need to show this and demonstrate the clinical impact in clinical trials, and they are ongoing now in the Tombola, Invigor 011, and planned in the modern trial also in this setting. And the question is, using this, before we get too excited, can we actually improve overall survival by doing this? Can we improve quality of life of the patients, and can we reduce costs? So that's some of the different things that are included in the different trials that are ongoing and planned also. The urinary tumor DNA needs to be investigated in larger detail. It needs to be protocolized in another way. Often it's something that we have from different clinical trials and cohorts, and we need to handle this in much better ways and better SOPs to really draw conclusions of this. Is it useful for bladder-sparing approaches, for instance? We need to figure that out. And ctDNA detections become more and more, they are evolving, they become more accurate and commercially available for easier use, so the whole genome sequencing approach may also be attractive in many genomic centers where you can actually do the whole genome sequencing in your own clinical facilities and upload this data for classification. So with that, I want to thank you for your attention and thank my team here who did a lot of the work, so thanks a lot.
Lars, that was a great presentation and so important. I wanted to ask you about your own personal view, which what I call monitoring, which you just described, which is completely agnostic to what might be the genomic activity of the tumor at its initiation, so-called tracker, where you first sequence, find the mutations, and then build a PCR test to monitor the patient, Signatera, and Foundation Medicine also, versus what you described, monitoring, which you don't need to know. You just do a really high quality NGS based on usually Illumina technology to detect any mutations. Which do you think has the long-term viability to follow bladder cancer patients?
I think the problem is if you're doing what you're describing as a tumor agnostic versus tumor informed test,
correct,
right? So if you do a tumor agnostic approach, then my concern is that we don't really know if the mutations we observe are because of clonal hematopoiesis, of course of other lesions you may have, and are you really able to start treatment initiation based on this if you cannot see anything on a CT scan. It's something else, of course, if you're in the other spectrum where you're doing screening. But screening, then we have excellent, I think it's excellent tests coming out from Grail and other where they're doing these large studies and see if we can actually do screening, but it will still be we still need to show from these studies that we see some stage shifts, and we actually have some benefits of doing these screenings. But I think in the tumor, I think a tumor-informed approach is really needed in order to have the sensitivity to detect this before we can see it on CT scans, and really have this hopefully window of opportunity to treat earlier. So I think that's important. It's more difficult, but I think it's needed.
No question, the Galsky data at ASCO GU 2 years ago, or 1.5 years ago, showed an 8-month window of earlier prediction of relapse by the Signatera approach, the informed approach versus change in imaging. So we really have provocative evidence that this is
it is important.
Coming in the future, maybe to the standard of care, to the standard of care.
That was a really great talk, Lars. For the Tombola trial, if patients have biochemical recurrence, they've already had metastatic disease, or what? So they're not metastatic to begin with, right?
No. We allow N1 disease is allowed, and then they can enter the trial.
Okay, so anytime they convert positive, they can enter the trial.
Yes.
Congrats. That's great.
Lars, beautiful talk. I was wondering if you can comment on the role that you see for ctDNA specifically in variant histology urothelials. Obviously, less common, but do you think there's opportunities, particularly with more aggressive tumor types, in terms of predicting things earlier where we could potentially biologically impact the outcomes of these patients?
Yeah, definitely. I think the opportunity is as great as we see for the studies I've shown here. But I think it's still key that we need to do tumor-informed testing of this. So I think the field is still in a place where we can do things after we have diagnosed the first tumor, and we can design these really sensitive and specific assays. And I don't think it really matters about the variant histology. There may be some issues about the biology and how much different variants are actually shedding circulating tumor DNA, and we need to look more into that. So,
Lars, great talk as always. I'm looking forward for the Tombola trial, hopefully maybe next year, right? The question I have for you is, if you can elaborate more following Jeff's question about the importance of tumor-informed versus tumor-agnostic, and it sounds like you favor tumor-informed based on what you answered to Phil. If you can elaborate on that. And the second question, if you can comment on the urine tumor DNA, do you think that it's mostly tailored for non-muscle invasive disease, or you think it may have a role in muscle invasive disease too? Thanks and great work.
Yeah. Thanks, Petros. I think for the tumor agnostic versus tumor informed, I think tumor agnostic, of course, has the hugest potential, because if you can actually identify new patients that need early TURBT or early treatment, and you're not working with patients that are already in the metastatic setting. I think if we can move it in that direction, I think there's a huge potential to actually start to save lives by screening and including patients early. But I think we need to see the results of those screenings yet, and see if they are sensitive and specific enough, and is it worthwhile doing these population screenings also, and is it added value? So we need to figure that out. So I think, but right now I think we are in a place where we can actually guide treatment in the advanced setting. Yeah. And your other comment about urine, I think, of course, we have seen trials in MIBC and for surveillance of relapse, and that's important, and they are ongoing. But I think in this setting I described here, especially for bladder preservation, I think it's really important that we optimize these protocols. We get more data, and we get more robust protocols also for collecting the urine specimens, because of course it has a higher variability compared to the blood samples. But I think the combined test, if the urine there's no mutations in the urine, it seems as if it may be safe to preserve the bladder, and if the blood test is negative also, you don't have any metastatic disease or maybe lymph nodes that need to be taken away during the radical cystectomy. So I think that combination together maybe with the DDR mutation analysis in the tumor to look at sensitivity to chemo and other things, I think that's important.
Thank you very much. We can close here. It's a great pleasure to call to the podium Andrea Limonti, a long-standing collaborator of ours. Andrea has labs in Italy and in Switzerland, I would say, and most importantly has been just appointed the director of Istituto Oncologico di Ricerca in Bellinzona.
It's fine. So thank you for the invitation, right? I promised that I would try to be on time. So this is my disclosure slide. So I will not lose time to discuss about the importance of prostate cancer in general. So my team has worked for many, many years in trying to understand how prostate cancer progress and become resistant to androgen deprivation therapy. So we have worked on genetic determinant which can promote tumor initiation, progression, and treatment resistance. However, today I'm not going to discuss about canonical driver of CRPC, such as, I don't know, mutation in androgen receptor, P53, RB, and PTEN, but on unknown driver of CRPC. The first driver is cellular senescence. So cellular senescence is a stable cell cycle arrest which occurs in all the cell of our tissue during aging. However, it can also occur in cancer cell upon different type of stress and chemotherapy, radiotherapy, or targeted therapy. So these senescent cells which are in the tumor are characterized by this positivity to SA beta-galactosidase staining and by different hallmarks. For instance, the cells do not die, so they're very difficult to kill. The reason is because they upregulate BCL2, so we need to really target them with the inhibitor of BCL2 if we want to eliminate. And more importantly, these cells secrete a number of factors in the surrounding microenvironment which are a source of chronic inflammation, which has been associated to essentially tumor progression. So there are many, many data that demonstrate that accumulation of senescent tumor cell upon therapy in different cancer can be a cause of chronic inflammation that, for instance, promote metastasis formation. And so my team has been one of the first to show in transgenic mouse model that this is the case. Indeed, the accumulation of senescent cell in a transgenic mouse model characterized by loss of PTEN and TIMP1, which is a regulator of metalloproteinase, is able to initiate the process of metastasis formation. However, and this is very importantly, elimination of the senescent cell through senolytic therapy that are currently used in the clinic prevent metastatic spreading in this mouse model of prostate cancer. Very interesting, in the same model, I think this is important for the oncology here, has been demonstrated that chemotherapy or even target therapy can actually accelerate metastasis formation instead to block metastasis formation. And this is the reason, I mean, if you have time to read this paper, can be due to the fact that the absence of TIMP1 in this genetic background can favor the tumor progression through different secreted factors that are oncogenic. But once again, elimination of this senescent cell in two different models. This is a humanized mouse model in which PC3 and TIMP are, in which PTEN and TIMP are deleted in the PC3 cell, again, is able to prevent metastatic spreading. So I try to go fast, right? But now I want to convince you that senescence can also be an anti-tumor mechanism. Indeed, I'm going to show you recent data that are submitted on cancer cells that show you that the properly designed combination of compounds can actually tilt therapy-induced senescence versus a favorable outcome. The story starts when Manuel Colucci in the lab was screening many different compounds in order to assess which of these compounds could enhance senescence in prostate cancer cells. And we discovered essentially that the RAR agonists are extremely effective in blocking tumor prostate cancer growth by inducing a cellular senescence, which is P21 independent. But why that's the case? Together with the bioinformatic unit in our institute, we were able to observe that up to 3,000 prostate cancer cases that the retinoic acid receptor signaling is strongly downregulated in prostate cancer in tumor progression. Therefore, that reactivation of this pathway is a new expose this tumor cell to a new vulnerability. However, what is very interesting to see and to notice that the presence of these RAR agonists in combination, for instance, with docetaxel that drive essentially in our constant even tumor progression, is able to tilt this tumor-promoting function of docetaxel in a tumor-suppressive function. Why that? Because this reprogram essentially the secretory phenotype, the SASP, of docetaxel-induced threat. This is represented here in this slide. If you take a cell that is treated with docetaxel or a combination of adapalene, which is a RAR agonist, together with docetaxel, and you put this in a co-culture condition with normal cell, so the cell that see the docetaxel-treated cell start to proliferate much faster. The one that see the combination do not proliferate efficiently. And so when we went in vivo, we also noticed essentially that while they might do not respond to docetaxel treatment, they efficiently respond to the combination of adapalene plus docetaxel. And this is also probably due to the fact that there is also an activation of the anti-tumor immune response. Indeed, we were able to notice that there was an increased recruitment of NK cells, which were also activated in the tumor treated only with the combination of the two compounds. So if we remove NK cell in mice treated with the combination, we actually blunt the tumor suppressive role of this combination of compounds, thereby showing that NK1 that are activated are very important for this, but not if we essentially remove T cell. And in an effort to develop a novel therapeutic opportunity for prostate cancer patients, we ask our question whether this combination of compound could also enhance the efficacy of human NK cells, which are derived by healthy subject. So we treat different tumor cells with either docetaxel or the combination of docetaxel plus adapalene. And when we co-culture them with NK cell, we were able to see that the pro-senescent combination of the two compounds was activating very strongly NK cell, only in the combo but not with docetaxel. So now I don't have time to show it, but this happened because the cell treated with the combination of compound a pregnant ligand which are capable to activate selectively NK cell. This upregulation of ligand of NK2G receptor, it happens only with the combination of the compound. So if we infuse in this PC3-SH-TIMP null mouse model NK cell, essentially the NK cell can kill efficiently tumor only when the mice are treated with the combination of compounds, but not when the mouse are either untreated or they are treated with docetaxel. So it's really the combination of compounds which synergize with NK allogenic infusion in order to drive an anti-tumor response. So I now want to show you that there is another non-conventional driver of castration-resistant prostate cancer that we have worked a lot for the past 5 to 10 years, essentially. And this is the tumor microenvironment. In particular, many years ago, we discovered that myeloid-derived suppressor cell, or also named immunosuppressive neutrophil, can actually promote prostate cancer progression and drive the onset of castration-resistant prostate cancer. This has been thanks to the contribution of Diletta Dimitri in 2014 that published this very beautiful Nature paper describing this population of cells for the first time, and Arianna Calcinotti in 2018 that published a follow-up paper. So what are these polymorphonuclear myeloid-derived suppressor cell or immunosuppressive neutrophils? So these are cells essentially that can come from the bone marrow of the patient. When the tumor forms, the tumor, in particular senescence tumor, start to release a number of secreted factors, including IL-8, which can bind to a receptor, which is called 6ER2 receptor, that is strongly upregulated in this polymorphonuclear myeloid-derived suppressor cell, thereby allowed that to be recruited into the tumor. So this happened also in a tumor sample from human prostate tumor sample, in particular in metastatic tumor sample. This has been done with Johan de Bono team that demonstrate the presence of this PMN-MDC also in metastasis, in particular an enrichment of this cell in CRPC biopsy. As demonstrated by Arianna, once these cells are in the tumor, they start to release factors that allow the cell to acquire the capability to grow in absence of androgen. So in other words, as also reviewed by Bagalski in 2018, MDSC recruited into the tumor release IL-23 that bind to the IL-23 receptor present on prostate tumor cells, thereby activating a signaling which promote androgen-dependent tumor growth. So we have now collected very interesting evidence and published this year on cancer cells that demonstrated that paradoxically also these immunosuppressive neutrophil can undergo to cellular senescence. And once they undergo to cellular senescence, they also can stay in the tumor much longer, up to 1 month, compared to cells which do not undergo to senescence. And this has been validated by multiple assays that demonstrate that these are indeed senescence neutrophil. They upregulate P16, P21, PI1. They upregulate BCL2, and they are also positive for SA beta-galactosidase staining. So, but why this is important? Because these cells accumulate, they have a much more tumor-promoting function, they release much more ROS, and additional factors such as IL-6 here in the tumor microenvironment, propelling tumor progression once again. And more importantly, therapeutically, we demonstrated for the first time that immunosenolytics, so therapy that kill senescence immune cell, can actually work by blocking the progression of prostate cancer. This has been shown here in a transgenic mouse model, but perhaps it's more easily shown here in this mouse model. We essentially, which is called RM1 mouse model, very aggressive mouse model, in which we use a combination of enzalutamide and romidepsin. Why that? Because romidepsin it's an HDAC inhibitor that can selectively eliminate this senescence neutrophil. And here you can clearly show that romidepsin synergizes with enzalutamide and even more with a 6ER2 antagonist that by blocking the progression of this prostate cancer very, very efficiently. So why this is important? So there are clinical implications of this data. So we have worked on bringing this to the clinic together with Jon de Bono for now many years. And we just published on Nature last week this paper. First author is Christina Guo, that is now work at Genentech, that actually demonstrated that blockage of myeloid suppressor cells, so this polymorphonuclear cell, can actually impact also in the clinic. This is in this paper, essentially we have, it's a phase 1 study. It's a very complex study in which we demonstrated that actually the 6ER2 antagonist is able to revert resistance to anti-ADT in patients that are metastatic. So patients have been treated, that have been enrolled in this study, have been treated previously with many courses of therapy, including docetaxel and enzalutamide abiraterone. And prior to re-enter in the study, where they are subjected to the 6ER2 inhibitor plus enzalutamide, they are retreated with enzalutamide to confirm essentially the incapability of enzalutamide to work. However, as shown in the study, we demonstrated that the combination revert enzalutamide sensitivity in at least 25% of the patient treated. Very importantly, by a proof of concept study, we show that this drug works by decreasing the number of circulating neutrophils in the blood, but also in the tumor biopsy of patients affected by metastatic castration-resistant prostate cancer, as shown here. So there is a correlation between the effectiveness of the drug and the reduction of neutrophils that infiltrate prostate tumor biopsy. This is the result of this study that showed that 25% of the patients have a partial response, and this is associated with a reduction of androgen receptor signature in tumor biopsy, and of course also a reduction of the input that allowed this cell, this myeloid cell, to be recruited into the tumor. So with this, I want to thank the people that make the job, and I already cited some of them and all the foundation that has supported my work. Thank you.
Thank you.
Congratulations, this is really amazing work. I was wondering what, I think this is the first time I've seen any data with NK cells and targeting MDSCs. Is there any scope for combining with checkpoint inhibitors? Are you looking into that?
Well, yes, so there have been previously a publication from around the Pignon lab that demonstrated that inhibitor of myeloid suppressor cell synergize with anti-PD-1. However, this has never been done in the clinic, so we would love to do that, right? At the moment we are working on a better inhibitor of this 6ER2, so there is a family member of 6ER2 is 6ER1. We think that the inhibitor that block both the receptor could be even more effective, and after we will try to do a combination. But if you are interested, I'm interested to collaborate in combining.
So, Andrea, fantastic talk, really enjoyed it. So, looks like P10 null tumors may be immunodeficient, simply speaking, immunosuppressed, not deficient. So have you gone back and looked at all those negative trials of prostate cancer with PD-1 inhibitors, PD-L1 inhibitors? There are at least 5 major trials. Is there a signal that P10 null patients in those trials may have benefited with PD-1 inhibition?
Well, I didn't do that. I think Jon did it, so he looked into that. He didn't find any correlation with failure to therapy. Yeah.
So it looks like MDSCs dominate.
Well, no, exactly. So also in this study, we were surprising to see that there was not an increased intratumoral recruitment of MDSC in P10 deficient tumors, right? So it's independent by P10, right? Okay. So so my hypothesis that despite the genetic alteration, there is a flux of this MD neutrophil in prostate cancer because of IL-8. It's so frequently, right, produced by many type of mutated tumor, right? So not only by P10 loss, but also MYC upregulation and so on. So
thank you.
Okay, thank you, but I guess we need to go on. Thank you, Andrea. And I invite the next speaker, Isalina Rowe from the URI, who will talk about addressing tumor heterogeneity in renal cell carcinoma.
Thank you very much for the invitation. So I'm Isalina Rowe. I'm a preclinical scientist. I'm working in URI in Milan at OSR. And I will present our project on how we deal with addressing tumor heterogeneity in renal cell carcinoma. So in the lab, we focus on the clear cell renal cell carcinoma because it's a more abundant histological subtype with the highest risk of metastasis. So it's in many of the cases is caused by the mutation in the VHL gene. And so in healthy cells, there is okay, thank you. Can you hear me? Yeah. So in healthy cells, there is a hydroxylation of the hypoxia-inducing factor, or HIF, and which is recognized by VHL, bound by VHL, leading to its degradation. But in the tumor cells, there is a mutation in the VHL gene and the loss of the P3 of the P arm of the chromosome 3, which leads to the absence of function of the VHL, and then HIF accumulates and goes in the nucleus, activating the expression of the target genes, which usually allow the cells to respond to hypoxia conditions, but in this condition it leads to tumorigenesis. But extensive genetic analysis have revealed that there are other genes that are involved. Many of them are localized on the same 3P, and they are mutually exclusive, and there are also chromosome imbalances. So in 90% of the cases is 3P, but there are also other losses and gains of other chromosomes. So the fact that there are these other genes which are mutually exclusive, mutated in a mutually exclusive way, makes that the different patients have different phenotypes, and so they have been stratified with different phenotypes, with corresponding to the different mutation and also the different outcome to therapy. And also, in the case of the treatment with belzutifan, which is a HIF2 inhibitor, here in a clinical trial made of the VHL patients who did not necessitate immediate surgery, the data have been shown that belzutifan is efficient, but not in all the patients. And almost half of the patients do not respond as well as the others to the treatment. And so there are markers for response for therapy, but until now, the only standard of care use the marker of the size of the tumor. And why? It's because there is a big limitation for the use of this marker, is that there is a high intratumoral genomic heterogeneity, which has been detected using multi-sampling detection. So how we want to unravel the RCC heterogeneity is first to analyze microenvironment analysis, so to study the cellular heterogeneity using serial cell analysis. In order to study inter- and intratumoral heterogeneity, we want to do multi-sampling, and we want to be in the condition of having the tissue specimens that could be used for the clinics. So we have the opportunity at San Raffaele to have the VHL program. So the patients affected of the von Hippel-Lindau disease have the germline mutation in the VHL gene, leading to the loss of function. And these patients have multiple CCLCC and renal cysts, leading to repeated surgery that can lead to morbidity or dialysis. But these patients have also manifestation in other organs. So as a pilot study, what we did is that we wanted to analyze the intertumor heterogeneity in one VHL patient, because in this case we don't have the difference of all the germline of the genetic background. So in this case, we took the advantage of the extreme case of the VHL patients who was enrolled in the VHL program and was elected for a left radical nephrectomy and a right kidney and a partial nephrectomy. So we took 5 tumors for the left kidney and 1 tumor for the right kidney, and one part of the normal parenchyma, and we did single cell RNA-seq, bulk RNA-seq, whole genome sequencing, and we take also a piece for histologic analysis and for pathologic, for one sample for each of the tumors and for the renal parenchyma. So what we observed is for the histological analysis revealed that the tumors were from 0.5 until 5.5 centimeters. They were all CCLCC. They were all grade 2, at the exception of one which was grade 3. they were all PT1A, except at the exception of one which was PT3A. And the fact that we follow the patient for a long time allows us to do the appearance detection with the imaging. So you see here that the first appearance of the tumor was in 2012, but the last one was 2018. So there was a lot of heterogeneity in the appearance detection. And in order to analyze the tumor background, we did single-cell RNA-seq using more than 10,000 cells from 5 tumors and 1 renal parenchyma. And we observed that we managed to observe the myeloid cells, the fibroblasts, CD8 cells, NK cells, and 1 cluster with epithelial tumor cells. When we checked for the disposition of the proportion of all the cells in each sample, we saw that all the different subtypes were present in each sample, but with a difference in a composition. For example, the more aggressive tumor had less CD8 cells in comparison to the other tumors. And when we checked for the expression of the therapeutical targets, we found that HIF2 alpha target score were higher in the different tumor cells from all the tumors in comparison to the normal part. The CD8 cells from all the tumor cells, but not the normal part, was expressed in the CD8. So the immune checkpoint marker coding for PD-1 was expressed in the CD8 from all the tumor cells, but not from the normal part. And the anti-angiogenic marker was expressed in the endothelial cells of all the tumor cells and the parenchyma part. So when we checked for the expression in the renal cancer cells from all the different tumors, we saw that there was differences at the level of the enriched pathway. For example, the smallest one has more expression of the immune response, whereas the more aggressive one had more expression of the mitochondrial metabolism and also the stress response. When we checked for the somatic mutations, we found that there was the same profile that has been found in the sporadic CCLCC with the 3 pillars and also the 5 gain, but there were also other chromosome gains and losses which were different in the different tumors. And all the different tumors were VHL monodriver. They didn't have other gene driver, at the exception of the tumor which was the more aggressive one, so the number 4. And in this case, there was a mutation in the BAP1 leading to a truncated protein which was missing the nuclear localization signal, so preventing his function. And when we checked for the BAP1 targets, we found that 100 BAP1 targets were upregulated or downregulated in comparison to the other tumors. So in conclusion, our protocol unravels the intertumor heterogeneity at the level of appearance datation, the level of histology, the level of size, the tumor microenvironments with a different concentration of CD8 and other cells. Also at the level of signaling, like metabolism, fatty acid metabolism and mitochondrial metabolism, the therapeutic markers, and the metabolism. And also we found at the level of genomics that most of the tumors were VHL monodriver and had a mutation in BAP1. And all the tumors have high chromosome instability with usual 3p and 5q gain. So now our next step is to do the project of a PNR that the PI Umberto Capitano. So in this case, we want to do the same, but in this case, we want to do also integrate this data with conventional multiparametric MRI to correlate this data with radionomic data, and also this time to do not only to take a sample, but to do biopsies, and not to do only one biopsy per sample, but to take 3 biopsies per quadrant, and to take 1 biopsy for single cell, 1 biopsy for DNA and RNA, and 1 biopsy for immunohistochemistry and histopathology. And after, we want to do also to test for another biopsy to do organoids and to test different agents on it. So this is the first that we did. This is a sporadic LCC. So the idea is to orientate the tumor as it is in the patients in order to correlate our data with the imaging. And so you see here that we divided the tumor in 4 parts, and for each part, you see here Umberto would take the biopsy in 1 part of the tumor. Thank you very much for your attention, and so thank you for the ones with who I have worked for this data. So Dr. Umberto Capitano, Alessandro Larcher, for the pathology, the one who do the assessment, Roberta Luciano, who also helped to take all the samples. For the whole genome sequencing has been done by Giovanni Battista and Francesca Correa. And also the datation has been done by Dottoressa Giorgia Guazzarotti. Thank you.
There are questions.
Iselin, a great work, and I know last night we were discussing over a beautiful dinner about the importance of having these multi-site biopsies, and we're discussing about the research autopsy program we have at the University of Washington, and I want your comments, how important that is and how you think this infrastructure is scalable, it's feasible to have in different academic centers to do a research warm autopsy in patients with VHL or other conditions. And congratulations on really, really nice work.
Thank you. Because we know the patients, I don't know, you have to ask for the MD, but I'm sure that is what we were discussing yesterday. All these patients, they are all accepting to be part of the research, and I'm sure that if we ask, there will be maybe a lot of them will accept to be part of a program of autopsy, but it's like because them, I think it's complicated. But we should ask to the urologists working with them. But I'm sure that a lot of them will agree to be part of this program. Yes.
So congratulations, I think, congratulations to San Raffaele for establishing and becoming part of the VHL Alliance. I've been on the credentialing committee, and I could tell you your application was outstanding when it was looked at by the VHL committee. One thing that I think your presentation highlights very clearly for VHL as clinicians is when you surgically operate on these patients, we have to remove all the physical tumors that we physically can, for the simple reason that obviously, as you nicely demonstrated, you can't assume that all the small tumors are necessarily going to be biologically indolent. And we also see that in sporadic kidney cancer. As we all know, kinetics is what we use when we have small renal masses in terms of when we intervene, but all surgeons in the room also know that sometimes we're very surprised. The small renal masses can behave sometimes much more aggressively with tumor thrombi. One of the most challenging cases I ever did was a 2 semirenal mass that produced an atrial thrombus. And I was scratching my head how this little tumor did so much intravascular extension of the disease. But I think there's very, very nice works which highlights, I think, the uniqueness of these tumors. You were going to say something?
Yeah, the more aggressive one was not the biggest one, which was surprising. But
may I add a question? I was wondering whether these different masses within the same organ give you a sort of picture of how the tumor can evolve, starting from the oldest lesion to the most recent, or each lesion behave differently as a single tumor, as an individual tumor?
No, you see that they have a different history, and you mean in the kidney?
Yeah.
Or
yeah.
in the
No, in the kidney. I mean, you have different lesions that appears very different one from the others.
Yes.
Do they represent a sort of individual tumors within this same kidney, or they represent the history of the tumor? I mean, the oldest lesion having some genetic characteristics that are common to the earliest and may represent how the tumor developed within this number of years, so that you can sort of design a trajectory of the tumor.
Yeah. So now, of course, it's only one patient, but we saw that the one which was more aggressive and was a really different datation from the other ones was the only one to have a BAP1 mutation, and we will need more patients to see if it was the case. But clearly, at the level of genetics, they were independent, genetically independent.
Okay, thank you very much again, Iselin. And as we are late, we have to move to the next speaker. Oncology and ongoing research.
Thank you very much to all. Thank you very much for Professor Montorsi, Professor Briganti, and my friend Andrea. My duty will be today to talk about the clinical aspect of clinical treatment of bone metastasis and bone health in genitourinary oncology patients. We started about some years ago with the ESMO guidelines, but after some years, I was co-extensor of the update of bone health in cancer, ESMO clinical practice guidelines, which are the topics and the novelties about the treatment of bone metastasis and bone health in genitourinary cancer patients. 3 points. One is one of the most important is the multidisciplinary approach to the patients with bone metastasis, and the decisions have to be taken by multiple specialists, orthopedics, radiotherapists, prostate cancer specialists, and supportive care specialists. And the second novelty is the reduced frequency of biphosphonates in the treatment of bone metastasis and the treatment of oligometastatic disease. The third aspect are the safety aspect. We have to talk about the rebound osteolysis when denosumab is discontinued. This is very important because can increase the risk of skeletal-related events or of osteoporotic fracture, and the supplementation by calcium and vitamin D. Bone biopsy. These guidelines confirm that when there is only bone disease, especially when there are few lesions and the imaging tests are not so clear, histological confirmation of metastatic disease is strongly recommended. The multidisciplinary team, as previously discussed with you, is very important. So every decision has to be taken by new multiple specialists. And I think that the introduction in the multidisciplinary team of palliative medicine specialists is very important for cure better patients with complication derived by bone metastasis. One other topic of the ESMO guidelines is the treatment principles. For example, radiotherapy. There is a liver evidence 1 and a grade of recommendation A of a single 8 gray fraction. Antiemetic and dexamethasone is suggested to minimize pain failure. And also postoperative radiotherapy should be taken in consideration after orthopedic fixation of a long bone or after spinal decompression or stabilization. When there is structurally important lesions in a long bone or in a spine, we have to evaluate also the orthopedic and spinal surgery as a primary treatment, if it is possible. Of course, it's better a prophylactic surgery for impending fracture to compare it to fixation after fracture. Vertebroplastic or kyphoplastic are a minimal invasive therapeutic option, but should be discussed in the multidisciplinary team. When is possible re-irradiation? Re-irradiation is possible, and when the bone metastasis is painful, and the need of re-irradiation may be higher after a single previous fraction regimes, is effective single fraction and demonstrated to improve quality of life and is less toxic than longer regimes. This is the national Italian guidelines published this month, and we recommend that in symptomatic bone metastasis from prostate cancer, radiotherapy in single fraction should be considered with the aim to control pain. But in some cases, for example, in patients with a neuropathic pain or in patients with impending fracture and life expectancy more than 6 months, may be considered a more protected fraction, for example, 5 to 10 fractions with a total dose of 20-30 gray. Stereotaxic radiotherapy now is used also for single or oligometastatic disease and should be considered in selected cases or in clinical trials. For example, there is a recent publication, meta-analysis, in which the authors compared the stereotaxic body irradiation of bone compared with the conventional external beam radiation. As you can see, in terms of a complete pain response at 6 months, in terms of local progression, and in terms of overall survival, there is a trend of increase of complete pain response, local progression, and overall survival in favor of stereotaxic bone irradiation. This is the interventional radiology approach. I'm sorry, it's in Italian, but if the aim is curative, the thermal ablation is the better choice. But if the aim is palliative, and if the bone metastasis is painful but without fracture or without impending fracture, the same thermal ablation could be an important choice. But if the bone metastasis is painful and there is a fracture or there is an impending fracture, cementoplastic or osteosynthesis could be the right choice for patients. This is the recommendation about the use of bisphosphonates and denosumab in bone metastatic castration-resistant prostate cancer patients because bisphosphonates and denosumab demonstrated to be able to delay skeletal-related events. This is a meta-analysis published 2 years ago in which denosumab was compared with zoledronic acid in terms of delaying SRA, skeletal-related events. And as you can see, denosumab seems to be superior to bisphosphonates in delaying skeletal-related events and in reduce the incidence of skeletal-related events. What to say about hormonosensitive prostate cancer setting? Our recommendation is the use of bisphosphonate or denosumab at metastatic dose is not suggested, is not a first option because there are no studies about denosumab and there are 3 phase 3 randomized studies of bisphosphonates that are negative. So the recommendation is strong at unfavored. The scheduling is most important because many patients now we treat with the zoledronic acid every month for the first 3-6 months, and then we can de-escalate the schedule of administration every 12 weeks. Denosumab should be administered every 4 weeks. We do not suggest to extend the interval beyond this 4 weeks. So this is very important because the AMI life of denosumab is very short because it's an antibody. Discontinuation of treatment for a reason in patients with metastatic disease is not recommended. And there are also some idea about some recommendation about safe administration of bone target agents. For example, this is very important. Bisphosphonates and denosumab may be combined safely with modern target agents with the aim to reduce the incidence, the frequency of skeletal-related events. Correction of vitamin D and deficiency and supplementation of vitamin D is strongly recommended. Bisphosphonates treatment are recommended when we, for some reasons, stop denosumab for more than 6 months because bisphosphonates treatment can overlap the rebound osteolysis related to stopping denosumab. But there are also some interesting news about bone health in prostate cancer patients. For example, for prostate cancer patients treated with androgen deprivation therapy, bisphosphonates and denosumab should be considered since the start of hormonotherapy for primary prevention of cancer treatment-induced bone loss. But there is not only bone loss because androgen deprivation therapy is able also to increase bone turnover, but also to increase fat body mass and decrease lean body mass. And so there is an increase of falls and an increase of sarcopenia, increase of phlogosis, and increase of risk of osteoporotic fractures. This is very interesting. These are the studies in M0 castration resistant, M1 castration resistant, in which they compared apalutamide or enzalutamide or abiraterone with placebo. And as you can see here, the incidence of not pathologic fracture in M0, but also in M1, the risk is increased in patients treated with enzalutamide, apalutamide, or abiraterone. So enzalutamide, apalutamide, or abiraterone are able to increase the risk of osteoporotic fracture in M0, but also in M1 prostate cancer patients. This is another example in M0 castration-resistant prostate cancer patients. As you can see, the incidence of fracture in Spartan, Aramis, and Prosper is double or triple compared to placebo. I think that what we can suggest in clinical practice in M0 hormonosensitive and M0 castration resistant is during androgen deprivation therapy is important to monitor vitamin D levels and to normalize the vitamin D levels in patients. So it's very important to use an induction dose and a maintenance dose of vitamin D. The physical activity and the calcium supplementation is mandatory, also to avoid weight increase, to decrease falls, and to increase the quality of bone health. The use of bone target therapy at osteoporotic doses as soon as possible, so in primary prevention, is very important independently from basal bone density in men treated with androgen deprivation therapy. And also for the denosumab and bisphosphonates, we have to use the osteoporotic dose for men with INADT. In patients with M1 hormonosensitive prostate cancer, also these patients can have osteoporotic fracture in sites not interested by bone metastasis, and we suggest to use osteoporotic dose for biphosphonates and for denosumab. In M1 castration-resistant prostate cancer, the dose used for metastatic disease are able also to reduce the osteoporotic fracture induced by the androgen deprivation therapy. So when we have to stop denosumab in bone health setting, this is a very interesting study because this is the incidence of vertebral fracture and non-vertebral fracture before the use of denosumab. During the use of denosumab, as you can see, there is a decrease of bone fracture. But when we stop denosumab, the bone fracture, the osteoporotic fracture increased in a significant clinical way. So what to do when we stop denosumab to avoid the rebound effect? In this multivariate analysis, only biphosphonates after denosumab demonstrated to be able to decrease the number of vertebral fracture in the rebound period after denosumab discontinuation. The last two slides to explain how the physical expertise exercise is able to increase bone mineral density in prostate cancer patients in hip and also in spine, but we have no phase 3 randomized trial that demonstrated that physical exercise are able to decrease the osteoporotic fracture, but only to decrease to increase the bone mineral density. I hope to be interesting about this topic, and I thank you very much again for the kind invitation. Thank you very much.
So, thank you. Presentation and questions. There is one question there.
Nice talk, thank you very much. My question is about intermittent androgen blockade. Do you suggest the same dosage, the same scheme, therapeutic scheme to preserve bone even in patient with intermittent? And I mean intermittent 3 months, then not 6 months as SWOG trial. Thank you.
Yeah. Thank you very much for the question, because this is very interesting topic. In the phase 3 randomized trial demonstrated that intermittent is not inferior to continuous. Between the secondary endpoint, there was also the incidence of osteoporotic fracture, and the osteoporotic fracture in the intermittent arm were not inferior to the compared to the continuous arm. So I suggest to continue the prevention and the protective bone health also when we do intermittent approach.
Okay.
I do also have a question. This is Matteo Bellone, one of the chair. I know that the bisphosphonates are toxic not only for osteoclasts, but also for macrophages, and M2 in particular. So, are you aware of any study that investigated the effects of bisphosphonates besides the bone preservation that might be a sort of adjuvant for the immunotherapy approach?
Yes, this is a very interesting question, because biphosphonates, yes, are toxic for macrophages, but are able to increase the gamma delta T cells. And the gamma delta T cells are very, very important because they are innate immunity, but they're able to have a control of immune system. There are many studies demonstrated that biphosphonates are able to immunomodulate the anti-cancer response, but there are no clinical study in which we studied the potential synergistic effect between immunocheckpoint inhibitor and biphosphonates. We published recently a study in which demonstrated that rank ligand levers could be a predictive factor of a negative response to immunocheckpoint inhibitor. So probably denosumab could be interesting in synergistic effect with immunocheckpoint inhibitors.
Thank you.
Okay, thank you very much again, Daniele, also for staying within the time. I think it's time now to go to the lunch. The lunch is